So it's already 3 o'clock, so I think we can start now. Dr. Leon and Dr. Joyce.
All right. Thank you, Dr. Samugan.
Dr. Leon, I will introduce first. Good afternoon, everyone. Welcome to the weekly webinar organized by College of Physicians Malaysia. We are now in Neurology Month, and the topic for today is autoimmune encephalitis. With us today, our speaker, Dr. Chin Man Leon. He is currently Neurology Fellow in Hospital Kuala Lumpur. And our chairperson for today is Dr. Joyce Pauline Joseph. Dr. Joyce is currently the consultant neurologist in Hospital Kuala Lumpur with special interest in demyelinating disorder. She is also PACTRIM's Central Organizing Committee member and PACMAN co-chairperson, as well as advisor for Multiple Sclerosis Society. So without any further ado, I call on Dr. Joyce to chair this section and subsequently introduce our speaker. Thank you.
So hi everyone. So I'm Joyce Joseph. I'm one of the neurologists in Department of Neurology, Hospital Kuala Lumpur. So our topic today is autoimmune encephalitis, and it will be presented by one of our specialists from the Department of Neurology, and he's also one of the neurology trainees. So Dr. Chin Man Leon has worked in several hospitals in Malaysia, in Miri, in Taiping, in Seberang Jaya, and in Ipoh. And he has participated in several industry-sponsored as well as investigator-initiated clinical trials. He's presented several posters, and soon he will be flying to Taiwan to present one of his cases. So without further ado, I now invite Dr. Leon to present.
Thank you, Dr. Joyce. Thank you for the kind introductions. The topics that today I'm talking about is autoimmune encephalitis. The lecture outline, including the pathophysiology of autoimmune encephalitis, clinical phenotype, and diagnosis. Then the emergency conditions and early treatment, and the response to immunotherapy in acute phase, and its maintenance therapy. Also, not forgetting screening for malignancy, for early resections and treatments, and prognosis and relapse. So we know that autoimmune encephalitis is these inflammations of the brain caused by the misdirected immune response against self-antigens expressed in the central nervous system, and is possibly as common as infectious encephalitis. This is the cartoon showing the postulated pathogenesis of autoimmune encephalitis. Blood-brain barrier acts as a protection to untoward inflammations or pathogens to the brain. But when there is exogenous factors, including infections or environmental factors causing blood-brain barrier dysfunctions, induce activations of innate immune cells, and because of that, it's followed by further monocyte recruitment and release chemokines, cytokines, causing activations of the lymphocyte cells, and hence causing mismatch or dysregulated cytotoxic response, antibody productions that act towards the brain cells. This is the timeline for the discovery of neuro autoantibodies. So the first neuroantibodies was discovered in 1965, anti-Hu antibody. This is a classical paraneoplastic antibodies that is intracellular antigens. The response to treatment is not so great, so hence the discovery of further antibodies is low. But not until 40 years later, the discovery of MMDAR in year 2007, and is very responsive to treatment and is common. And since then, there are exponential discovery of more neuroantibodies. The classifications of autoimmune encephalitis can be broadly divided into anatomical, serological, and etiological classifications. For the anatomical, some of the antibodies have certain tropism to certain parts of the brain. So the most common for autoimmune encephalitis is limbic involvement. Then the others to cortical, subcortical, striatal, dyencephalic, brainstem, cerebellar, encephalomyelitis, meningoencephalitis, or combined of the anatomic of inflammation in the brain. For serological classifications, the antibodies, there are four, which the first one is the antibodies to intracellular antigen, which are the classical onconeuronal antibodies. For example, is the anti-Yu, Rima, Ana, then which they are not so responsive to the immunotherapies. The second is the antibodies to surface antigens and other antigens with high clinical relevance. Means the antibodies is acting directly at the surface antigens, causing the pathogenic clinical syndrome. For example, is MMDAR antibody, AMPA, LGI1, CASPA2, GABA, RAB, TPPX, glycine, and the others. Then also antibodies to surface antigens with low clinical relevance, and also not forgetting seronegative autoimmune encephalitis, which patients have a typical autoimmune encephalitis syndrome, but have yet to have antibody to be discovered until this day. The etiological classifications can be idiopathic, paraneoplastic, post-infectious, or iatrogenic. Why autoimmune encephalitis is important? Because clinicians should have high index of suspicions to clinch the diagnosis of autoimmune encephalitis. The early immunotherapy yield good recovery for the patients. And also, some of the autoimmune encephalitis is highly associated with malignancy. So screening of malignancy and for further treatment is very important. Whom patients that we should suspect autoimmune encephalitis? There are variable presentations of autoimmune encephalitis. The most commonly is the cognitive function decline for the patients. So the patient presented with working memory deficits, which they are disoriented, they have disorientated to time, place, disorientated to people, visual spatial disorientations, and also amnesia. Then they also presented with psychiatric, neuropsychiatric behavior, like hallucinations and agitations. The others, like movement disorders, they have stereotypic movements. They can have chorea. They can have tremors. Then also they can present with epilepsy, can be focal or generalized tonic-clonic seizures, and also the typical facial brachial dystonic syndromes from the LGI1 phenotypes, and also sleep behavior changes. So the immune reaction in autoimmune encephalitis is usually diffuse, which result in polysyndromic presentation, which means they're presented with combinations of the above neurological deficit, and this is the hallmark of autoimmune encephalitis. The presentation is usually subacute, but sometimes it can be progressive onset, chronic, which cause delayed diagnosis. And there are well-known clinical phenotypes related to the specific antibodies. The symptoms often overlap from the specific antibodies. And also, we are not going to discuss about the other autoimmune CNS disorder with distinct entity, like the cerebellopathy, stiff person syndromes, or PERM. Okay, this is the chart to show the well-known clinical phenotype of autoimmune encephalitis. So the most common is MMDAR antibody. It usually happen in young female, presented with acute onset, acute to subacute with onset. There will have mixed psychopathological at onset and complex movement disorders. They have stereotypies, rhythmic complex movements, often with hyperkinetic catatonic fluctuations and dysautonomia. Then for LGI1, GABA-B, CASPA2, they are usually happen in more elderly patients. Epilepsy seizures or status epilepticus commonly associated with MMDAR, GABA-B, GABA-A, autoimmune encephalitis. And the typical presentations for LGI1 is facial brachial dystonic syndrome, where with high index of suspicions, when the patient first presented with facial brachial dystonic syndromes, and early recognitions and early treatments can prevent the further progressions to amnesia and also epilepsy, which yield a better prognosis. Then for CASPA2, the typical presentation, the special presentation is the patient will complain of pain and cramps. Okay, for GABA-A, MRI, there will be typical prominent cortical and subcortical hyperintensity in the MRI. For MOG, the patient usually are young and they present like Adam, with drop in GCS. Then glycine R encephalitis, they will present with rigidity, hyperreflexia. Same with DPPX, present with myoclonus and hyperreflexia. Okay, from the clinical phenotype, so we can see that they usually present with multiple neurological deficits. Okay, how? What is the approach to diagnose autoimmune encephalitis? What is the diagnostic criteria and how to manage the patients? We have case presentation. A 24 years old lady, have no known comorbid. She presents with alter behavior. She shouted to family members for 1 week, and he came to ED hospital because treated in GTC nature. In assessment in ED, the patient is disorientated to time and place, still can recognize her parents. GCS is 14/15, she's confused, tachycardia, and there is fever. Physical examinations shows no lymphadenopathy. Lung CVS abdomen is normal. The pupil is 3 reactive. She has blood vocalizations, agitated, stereotypic bilateral by lower limbs and upper limbs, and she is not obeying command. The muscle power is 3, at least 3, no neck stiffness and no myoclonus. You can see the patients have rhythmic cyclical movement of the bilateral lower limb, which can mimic psychogenic seizures, and also stereotypic movement of the left upper limb. There's loud loud shouting from the patient and in agitation pose. patient not really obeying command. This is not the video of my patient. This is taken from the from one of the journal for education purpose. So further investigations, the routine are normal. The white cells also fairly normal. CRP is 35. CCT brain is normal. LP global puncture, the protein is slightly elevated. 1. The glucose ratio is 0.5. The cell count is 50 cells with 100% lymphocyte. TB and others are no negative. The viral workup is pending. So the plan is cover antibacterial, antivirus, and other supportive management. So until now, the differential diagnosis is meningoencephalitis, autoimmune encephalitis, altered behavior throughout acute psychiatric disorder, metabolic encephalopathy, Hashimoto, or could be temporal lobe glioma. So this is the diagnostic criteria proposed by Krauss for possible autoimmune encephalitis. So the diagnosis can be made when all three of the following criteria has been met. The first one is a subacute onset. There are the autoimmune encephalitis, they have rapid progressions of less than 3 months, usually with working memory deficits, altered mental status, or psychiatric symptoms. Then the second criteria, at least one of the second criteria, including new focal CNS finding, seizures not explained by the previous known seizure disorder, CSF phagocytosis, MRI features suggestive for encephalitis, and also after excluding other alternative causes. So detailed history and examinations that points toward autoimmune encephalitis is usually they will have prodromal, viral-like prodromal symptoms. The 2 weeks prior to the acute presentation, they might have viral infections or fever. And autoimmune encephalitis may be triggered by herpes simplex encephalitis or certain iatrogenic drugs like tumor necrosis factor inhibitors or immune checkpoint inhibitors. And from the history, they are usually presented with isolated psychiatric features at disease onset. And as the disease progresses, a few days later, they will have rapidly decline, with showing more traditional neurological deficits like delirium, amnesia, and seizures. Atypical presentations like hyperacute presentations are atypical, and vascular etiology have to be considered. Sometimes chronic presentation can be seen in autoimmune encephalitis, like for LGI1, CASPA2, DPPX, GAT65, DFFT, astrocytopathy. And otherwise, if the patient presents with chronic presentation, we have to rule out other causes like neurodegenerative disease. Lumbar punctures is the most important investigation for autoimmune encephalitis. The commonest finding is that there are mild to moderate lymphocytic phagocytosis, usually 20 to 200 cells. Then the CSF protein is elevated, and there will be elevated IgG and positive intrathecal oligocorner bands. Usually it's unmatched in the serum. Most antibody is more sensitive from CSF sampling, except for LGI1 and acroporin 4 antibody for NMOSD. But however, whenever possible, PET CSF serum should be tested. This is the usual autoimmune antibody panel that we send. The autoimmune panel 1, including AMPA, CASPA2, LGI1, GABA-B, MMDAR, DPPX. Then the paraneoplastic antigen autoimmune profile, and also the demyelinating or autoimmune CNS causes like acoporin 4 for NMOSD and also more antibody. What is the further test? EEG is really specific. The finding of the usual autoimmune encephalitis finding for EEG is focus slowing or generalized slowing, lateralized periodic discharges, or sometimes extreme delta brush, which is quite specific for MMDAR, MMDAR antibody encephalitis. By doing EEG, also we can rule out other differential diagnoses like CJD, which we can see complex periodic discharge, or to review non-convulsive seizures. And then MRI brain. Some other tests to exclude other differential, including but not exclusive of including toxic and metabolic causes, nutritional, infections, HIV, hepatitis B, hepatitis C, PDRL, herpes simplex, varicella zoster, connective tissue disease, primary CNS demyelinating, neurodegenerations, and encephalopathy. Okay, now let's look at the MRI finding of autoimmune encephalitis. This is the anatomical subtype of autoimmune encephalitis. A is hyperintensity located at bilateral mesial temporal, which is commonly seen in limbic encephalitis. B, hyperintensity at cortical and subcortical at the bilateral temporal regions. C is a striatal encephalitis. You can see hyperintensity at the caudac. D is the encephalic encephalitis, which patient will have a lot of dysautonomia. E is brainstem encephalitis. You can see hyperintensity at the brainstem. And F is the meningoencephalitis. You can see there is meningo enhancements, which can be seen in the GFAP encephalitis. When the patients have bilateral hyperintensity at the patients have bilateral T2 hyperintensity restricted to the medial temporal lobe, and patients fulfill the possible criteria for autoimmune encephalitis, can clinch the diagnosis of definite autoimmune encephalitis. Because in other causes like herpes encephalitis, usually the inflammations not only involving the mesial temporal part, it involves the temporal lobe, and also there will be hemorrhagic changes seen in the gradient echo from the MRI in the herpes encephalitis. Okay, we have done step 1 and step 2, and not forgetting to screen for autoimmune neoplasm. To screen for neoplasm, including CT, TAP, mammogram of breast, MRI for lady, pelvic and or testicular ultrasound, and if all the screening for malignancy is negative, we should proceed with PET scan. FDG PET scan can be done if MRI is negative or unable to perform MRI. It's more sensitive than MRI for autoimmune encephalitis. The typical features is there is bilateral temporal hypermetabolism. You can see over the right side is hypermetabolism in limbic encephalitis, which in MRI image is not so obvious. And others findings like bilateral occipital parietal hypometabolism in MMDAR antibody encephalitis. So after a few days, the patient deteriorate. She developed status epilepticus of GTC in nature. is not abort by giving midazolam and also phenytoin loading dose. And so she was intubated for airway protections and started on anesthetic agent. Okay, now we go to what are the emergency conditions that can be related to autoimmune encephalitis. NOS stands for new onset refractory status epilepticus. 30% is due to autoimmune encephalitis. Patient can have refractory status epilepticus, which can be life-threatening and presented with very frightening conditions to the clinicians and also to the family members. They can have low GCS and respiratory compromise, like seen in ADEM of encephalitis with brainstem involvement. They can have dysautonomic with bradyarrhythmias, like in certain cases of MMDA encephalitis, which might need temporary pacing. And also severe hyponatremia in LGI1 antibody encephalitis. So the next step is early and aggressive immunotherapy, which is associated with better outcome in autoimmune patients, autoimmune encephalitis patients, after excluding the infections, while still waiting for the autoimmune antibodies. The observational data show that steroid might be beneficial in some form of herpes simplex encephalitis, suggesting that the steroid may not be the universal contraindications for herpes simplex encephalitis. However, in the observational studies, they are just using prednisolone or dexamethasone, and also other management like status epilepticus, like for status epilepticus or movement disorder. This is the diagram to show what are the flow chart of giving first-line immunotherapies. So when the patient have highly suspicious of autoimmune encephalitis or confirmed autoimmune encephalitis, we ask ourselves, is it likely a paraneoplastic autoimmune encephalitis where usually the patients are elderly and also risk factor for malignancy, or the patients, the causative of autoimmune encephalitis is idiopathic. So for mild to moderate autoimmune encephalitis, there are 3 options available: methylprednisolone, house, IVIG, or PLEX. Methylprednisolone is the first line, and if the patients have contraindication to methylprednisolone, for example, they have uncontrolled infections, they have uncontrolled sugar, DKA, like DKA, or they have uncontrolled neuropsychiatric behavior, other agents might be preferred. IVIG have more evidence than the rest of two, but the author from the study, from their experience, that IVIG is not as good as methylprednisolone and plasma exchange. When the patients have high bleeding risk or agitations, IVIG might be the preferred choice. If the patients have high thromboembolic risk or severe hyponatremia, PLEX is the preferred choice because IVIG can worsen hyponatremia. If the patients have very severe autoimmune encephalitis, which they are presented with nose or severe dysautonomia, combinations of the two first-line immunotherapy are preferred. And if there is no improvement, you should go to the second-line immunotherapy. If we suspect paraneoplastic autoimmune encephalitis, the first line that should be given is methylprednisolone. Then actively screen for tumor and further resections and treatments. If there is no improvement, the second line is cyclophosphamide. This is the timeline for MMDAR encephalitis. can see patients usually presented with viral prodrome and will progress within days to weeks and reach recurring ICU admissions in severe cases. If the treatments can be initiated earlier, the curve is as the patient can recover. 50 to 55% of the patient responds to first-line therapy. And if the patient is not responding to first-line therapy, we have to quickly initiate second line, usually within 2nd to 4th weeks of presentations. And yeah, the second line therapies will improve 70% of non-responder to first line. The second line therapy, including rituximab, which is the CD20 B cell depletion, also have effect for autoregulatory of T cells mediated immune response. The others are cyclophosphamide, is acting for the T cell mediated autoimmune encephalitis. Usually it's for the paraneoplastic or onconeural antibody related. The new agent that in pipeline is tocilizumab or bortezomib. For patients who fail second line or second line immunotherapies, the options available is tocilizumab, interleukin-6, or bortezomib, the plasma cell depleters. We have shown in case study have effective response to the autoimmune encephalitis patients. We know that 50 to 60% of lady presented with autoimmune presented with MMDAR antibody encephalitis have teratoma. So teratoma removal is the key step for the treatment for these patients. For prognosis, proposed by Krauss, 1 year outcome is reduced if 1 year outcome of achieving MRS less than 2 is reduced if there is delay in treatment more than 4 weeks. So early detections and early treatment is important, and also if the patient presented in the more severe form, which require ICU admissions, abnormal MRI, or high CSF post-cytosis associated with poorer outcome. Okay. For the maintenance therapy, antibody-mediated autoimmune encephalitis can be monophasic, and maintenance therapy can often be stopped after 1 to 3 years. Okay, so the patient just now, after immunotherapy, she recovers after some time. So for autoimmune antibody interpretations, is very important. Substantial numbers of patients do not present with a well-defined syndromes. So the measurement of autoimmune antibodies will clarify the subgroup, the tumor associations, and the prognosis. And detections of autoimmune antibodies establish the diagnosis for patients who do not satisfy the indicated criteria. The serum MMDR antibodies can occur in 3% of healthy subjects. So CSF negativity is considered to indicate a lack of direct autoantibody pathogenicity for MMDR and others, except for LGI1 antibodies, encephalitis. When with comparable autoimmune encephalitis clinical syndromes, and they have no undetected autoimmune antibodies, we must bear in mind it could be seronegative encephalitis. The method used to detect antibodies, it could be classified into single or multiple. We'll go to this. This is the pattern of staining for the immunofluorescence and cell-based assay. Based on the pattern, the pathologist can recognize what antibody are involved. The pro and cons of testing. For the immunohistochemistry, it is not so not so sensitive, but it's specific. Low sensitivity, but it's specific for detections of the disease. So sometimes if the patients have negative immunohistochemistry, we should proceed with cell-based assay, which is more sensitive, but it's less specific. The other types like flow cytometry is not operator dependent, which is for aquaporine translated cell line. You can see that autoimmune encephalitis usually presented with multiple neurological problems. So interdisciplinary care is required for the patients. Like neurologists with different subspecialties involving epilepsy, neuromuscular, cognitive and behavior, movement disorder, sleep medicine, neuro-oncology, and also psychiatrists for the psychotropic medications and management, psychology for mental health resources, neurophysiology for cognitive assessment with adaptive strategy, and also other medical subspecialties, rheumatology, GI, respi, cardio, the primary care providers, and also not providing rehab services for rehabilitations, physio, occupational therapies, speech, and also patients and caregivers, and provide adequate resources for patients and caregivers. And with that, I thank you for your attention.
Thank you, Leon. So now we invite the audience to send in your questions through the Q&A column. So I will be reading out the questions and Dr. Leon will answer them for you.
All right.
So we do have one question. For IV methylprednisolone for autoimmune encephalitis, is it weight-based or 1 gram daily for 3 to 5 days? That is first question. And do you correct the hyponatremia in anti-LGI AE?
Okay, from the literature is weight-based, is calculated based on the body weight. But what we usually give is 1 gram per day for 5 days. From the literature is 20 to 25 milligram per kilo per day. For the hyponatremia, yes, corrections, but has to be slow and have to be slow, less than 10 millimole per day. And too fast, the overcorrections of the hyponatremia can cause another problem, pontine binding osmolytic syndrome.
Yeah.
Yeah.
So
yeah.
I agree. The usual dose. Do continue to type in your questions. Yes, the normal methylprednisolone dose we give is 1 gram for 5 days, just like any other autoimmune conditions. So it can be weight-based too. So it's an individual choice, but the normal dose is 1 gram for 5 days. So one more question by the audience. What do we use for maintenance therapy?
Yeah, for the maintenance therapies, is immunosuppressions. So we know that by giving steroids, patient will have a lot of side effects from the steroids, including Cushing's, acne, diabetes. So steroid will be given for a short period of time until the second steroid-sparing immunosuppression effect set in, like 3 to 6 months later. The most commonly used is azathioprine or MMF. But before the second steroid-sparing agent set in, steroid will be used first. Then, after a while, steroid will be tapered down, and we continue with the steroid-sparing immunosuppressants. So for more severe form, others immunotherapy can be used, like IVIG or rituximab. Yeah.
Okay, one more question, Leon. Why is NMDR encephalitis associated with teratoma in female patients?
It's postulated that the body, even before the discovery of teratoma, the body generate antibody to try to act on the teratoma so that it will not grow further. But then, because of cell mimicry, the antibody also act on CNS cells and causing all the symptoms that were described earlier. So it's highly associated with teratoma, and you should screen for teratoma when the lady presented with NMDA encephalitis.
Okay, so a number of questions, Leon.
Okay.
When should we have a high index of suspicion for AE?
Yeah, the presentation usually is subacute, means they're presented with rapid declines in the periods of less than 3 months. So, and with combinations of the neurological domain, like we described earlier, for the autoimmune encephalitis, the most common is cognitive decline. So they have altered behavior, they have confusions, change of behavior, talking irrelevantly within the periods of 3 months. Then you should suspect autoimmune encephalitis.
Okay. Yeah, I guess we just need to follow the criteria that you mentioned, right, Leon?
Yes. Yes.
Rapid cognitive decline, seizures, right?
Yes.
And especially in NMDR encephalitis, I think seizures, encephalopathy or cognitive decline and movement disorder is already a high index suspicion for NMDR encephalitis, right? Autoimmune should be considered, but
yeah, it's very as the discovery of more antibodies, so it's become more common.
okay. So is there a difference? Another question for you, Leon. Is there a difference in maintenance therapy duration for different autoimmune encephalitis? And how do we decide when to stop maintenance therapy?
Yes, actually there is no clear guideline for the maintenance therapy. So for the autoimmune encephalitis that deemed to be monophasic, and it can be stopped after 1 to 3 years. But for more severe types of autoimmune encephalitis, and we would prefer to continue the maintenance therapies. Yeah, there's no clear guideline for which type of autoimmune encephalitis for the. durations of maintenance therapy.
So another question. Hi, Dr. Leon. In the case of AE secondary to a neoplasm, such as ovarian teratoma, is the AE curable after removal of the neoplasm? What are the recurrence rates?
Oh yes, the AE, especially for the refractory types of AE, after removals of the presenting neoplasm, the response is better. Not to say 100%, some literature quoted 50 to 60% recovery. Of course, they will have the sequelae from the damage due to the antibodies. Yeah. So the recurrence depends on the natures of the malignancy. So if if it's a malignant, so the prognosis is based on the malignancy, the nature of the malignancy.
And after given a combination of IV methalpred and IVIG, is it okay to give rituximab straight without waiting for 4 weeks if clinically no improvement?
Yes, in clinical no improvements means there is no improvements in terms of MRS. There's no improvement of MRS less than 2 within 2 to 4 weeks, and second line therapy should be considered. Because like in MMDAR encephalitis, for the non-responder to the first line immunotherapies, 70% of the patient will respond to the second line immunotherapies. And also, if given the second line antitherapies, the relapse rates later will reduce and patient outcome will be better after 1 year. So yeah, it should be considered.
So will you do both serum and CSF autoimmune encephalitis panel?
Yes, it's advisable to send both serum and CSF panel because most of the antibodies is more specific from CSF sampling, but however, only a few certain types like LGI1, MMO is more sensitive. It's more sensitive from the serum sampling. Yeah.
And do you repeat lumbar puncture to test for seroconversion of antibody after treatments for AE?
There's no guideline because the antibody is not directly related to the severity of the disease and also with relapse rate. So of course, there is a rule of repeating the lumbar puncture if there is clinical suspicions of other disease or other differential diagnosis.
Yeah, I agree, Leon. We normally don't repeat the lumbar puncture. As you know, as it is extremely difficult to get a lumbar puncture done. And to repeat one will be even more challenging. And yeah, I've not read a guideline which asks you to repeat either. So do we start regular anti-epileptic for AE in patients with seizure? And is there anti-epileptic of choice for AE?
Yeah, so the anti-epileptic, we start anti-epileptic if we think that the patients have high rate of recurrence of epilepsy. When we think patients have high rate of epilepsy more than 50%, so it can be started. But usually patients presented with acute symptomatic seizures. So we are not very sure that patient will have anti-epileptic or not. But if the patient presented to you with multiple fits, so anti-epileptic should be started for the initial phase so that there's there's reduced damage to the brain cells. Yeah. What types will depend on the clinical situations. If they have generalized epilepsy, the loading usually is phenytoin, the usual one, phenytoin, Keppra, or epilim. So after the loading, the antiemetic should be continued for the patients.
Okay, so this appears to be a last question. We do have 10 more minutes, so if you do have more questions, do keep them coming in the Q&A box and we will answer them for you. So your last question at the moment, Leon, is I have a patient with whom diagnosed with NMDR before. There were times she came several times due to abnormal behavior and seizure. Is there a way to differentiate abnormal behavior due to relapse, NMDR versus ictal, post-ictal psychosis?
Okay, so if the patients have already confirmed to have MNDR encephalitis, and of course we must think of relapse for the patients, because early treatments will yield good response and recovery. So but also we must not forgetting the other differential diagnosis, including any metabolic causes or seizures. Right. I mean, if the patient have non-convulsive seizures, patient can present it with confusions and that. So further investigation will clarify that, including lumbar punctures or that. Further history taking, yeah. With good clinical assessment and investigation, we should differentiate. We should be able to differentiate whether it's a relapse of MMDA or it's just due to other causes like seizures on and the response, and also can look at the response to the immunotherapies. Yeah, is there any change in immunotherapy, which patient not compliance to the maintenance therapy, or any change in antiepileptic that causing breakthrough seizures.
Yeah, probably ictal will be easier to define, right? Ictal will be just an ictal EEG that can be seen. Post-ictal, I think post-ictal psychosis, there's a set of criteria that we can follow. Okay, so is there a role of repeating EEG in autoimmune encephalitis?
Yes. Depends on the clinical context. EEG can be repeated, especially during the acute phase. So after the sedations, patient might have non-convulsive seizures. So repeating the EEG can capture that and give appropriate treatments to prevent further brain inflammations and further damages to the brain tissues. So EEG is indicated in some certain clinical contexts. For chronic cases, if the patient does not recover, so EEG is also important to tell us what's the background of the EEG, background of the patient, what is the recovery, like that.
Okay, so I think we have no more questions, but I would like to ask you a question, okay. Leon. So you have worked in several hospitals, Leon, Mary and Ipoh and Taiping, so and HKL now. So can you tell me the challenges that you faced in diagnosing and managing autoimmune encephalitis?
Oh, there are many challenges.
Share with us.
Is the patients, one is from the patient perspective, especially based on their background. Some of the patients, they might come late They usually seek, because of the cognitive decline, seizures, because of stigma, they will seek traditional medicines first before coming to see a doctor, until they become very ill, already have no other options, they will come to our setting. So the treatment for the autoimmune encephalitis is delayed. Then the procedure like the lumbar puncture is the most important investigation, but let's say most, 20-30% of the patients refuse the procedure. Is actually quite a routine investigation for us to do on the CNS patients. Quite safe. Then the other thing is the investigations. So how extensive that you want to go to look for the antibodies, and the turnover time for the investigations. Private, they will have faster, which is a burden to a patient. Yeah. Then the MRI scan in some hospital setting, the MRI slots might be delayed, or because of the hospital setting. Yeah.
True. I think sending the autoimmune screen is challenging too, because of the cost factor, right?
Yeah.
And delay in diagnosis, yes. And in a center with no EEG or MRI will be also challenging. Yeah, there are quite a number of challenges. And also in a center where we have seen or have a high index of suspicion based on clinical features, we tend to diagnose early, right? So maybe in a hospital with no physicians or neurologists, that might be tough. There will be a delay in diagnosis, right? As we know, autoimmune encephalitis is a new disease, right? It's not there in many of the textbooks, even for the medical students, right? So yes, delay in diagnosis can happen. So any final thought or word of advice for everyone in managing autoimmune encephalitis, Leon?
Yeah, you should have high index of suspicions for autoimmune encephalitis, because it is deemed as common as infectious encephalitis. And early treatments will have good recovery for the patients.
Yep. So if there has been no other questions, so thank you, Dr. Leon, for your excellent and comprehensive talk. So we now hand over to Dr. Shan.
So I'd like to take this opportunity to thank Dr. Leon and Dr. Joyce for sharing their knowledge with us today. And we hope to see you all next week for another neurology topic. With that, thanks everyone for attending this webinar. Thank you, Dr. Leon and Dr. Joyce.
Okay, bye-bye.
To participant, doctors, we will apply the CPD point for you guys. We don't tak ada QR code today. So, and for those nurses and other professional healthcare, we will send you a certificate as soon as possible. Thank you very much and have a good day.